we go. Thanks everyone. Thanks Ash. This has been total. This is like the last 5 minutes before we jumped on. Everybody doesn't realize this, but it's been total chaos, just total damn chaos because nothing was working. No one could get on. We couldn't hear Ashley. Mike wasn't on. Dr. LaPrade just jumped on in the last second. So we're going now. This is great. We're gonna have a good meeting despite the last minute issues. Hi, I'm Rob Mansky from Wichita State University. Thanks for joining us tonight. We got two great speakers. First of all, I'll let Phil, my man Phil, introduce himself real quick before we get going, and I'll introduce our speakers.
Hey everybody, it's Phil Page from Baton Rouge, Louisiana, professor and research director at Fran U in Baton Rouge, doctor of physical therapy program. Honored to be here. How many is this, Rob?
Oh my gosh, I should have looked.
28.
20, is it 28?
I don't
20,
know. Ash,
where we go?
anybody?
28,
20.
29, something like that. I don't know. See, it was pandemonium. I didn't even get the number. I usually have the number too. But so let's welcome our guest. Thank you both so much for joining us. We've been trying to get these two on for quite some time, and Jill's put us off and put us off and put us off. But she finally said yes. She'll get herself and Dr. LaPrade on. So it's great to have them. I'll introduce Dr. LaPrade first. He's a complex orthopedic knee and sports medicine surgeon who practices in Twin Cities Orthopedics in Minnesota. Those of you that have heard of Dr. Prad, probably LaPrade already know this. He specializes in comprehensive research of sports medicine injuries to improve patient care. He's come up with all kinds of ways to do knee surgeries, just novel things that people probably never even heard of that he does just so eloquently. Many of the surgeries that he has devised have been performed worldwide. He has special expertise in treating posterior lateral knee injuries, PCL injuries, revision ACL reconstructions, meniscal repairs, and transplants, MCL injuries, multiple ligament knee injuries, knee osteotomies, fresh osteoarticular allografts, and other difficult, complex, and revision injuries. And we could just go on and on. We could go on for the entire hour, I think, just talking about all of his accolades. So thank you, Dr. LaPrade, for joining us tonight. We really appreciate it.
Thank you. I'm looking forward to it.
And with Dr. LaPrade, we have Jill Monson. Jill's a great addition to our AASPT family. She's a lead physical therapist for the Complex Knee Injury Clinic and practice with Dr. LaPrade. She leads a team of clinicians across the TCO system, oversees postoperative rehab protocols and care progressions, postoperative patient testing and data collection protocols, rehab-based research initiatives, continue education content, again, and we could just go on and on forever. Jill's a member of the ASPT Research Committee, and we're fortunate enough, I'm on the committee too, we're fortunate enough to have her on the annual conference planning committee. She's one of the reasons we had such a great conference earlier this summer. So thanks, Jill, for all you do, and thanks for joining us.
Thanks for hosting us, Rob. I really appreciate it.
So Jill, before we start, we'll start with one of the studies, but tell us what what is it like working with Dr. LaPrade? It's got to be amazing and probably I'm guessing maybe a little stressful seeing some of the patients with some of these unique surgeries. What's it like day to day working there?
He's just waiting to hear this answer. So, it's which iteration, right? Because this is round two for us. We started together at the University of Minnesota. Oh my gosh, 2004, 5, and that was pre-Vail. And I started to ask a lot of questions and bother him, and he would refer me to certain papers he'd written. And during that time, I was doing a lot of learning. And then he took his tour out to Vail. And when he came back, we got back together, got the old band back together again. And it was a lot of relearning. These aren't the types of patients that you see every day. So I had to knock the cobwebs out a little bit. And he's an amazing teacher, and we rarely see anything that's just straightforward. So you're always spinning multiple plates, which I think is a great exercise for your PT brain. And he really values and champions our profession. So it's awesome. I will say last Friday we were in the lab, the biomechanics lab, where they were doing a dissection, and some of the new fellows were learning procedures. And that's where he loves to be and shines. And he was touring through the knee and showing surgical techniques. And then we walked over next door and looked at the robot, which was currently testing a new surgical procedure. And it was just like, and we were right across the hall from our therapy center and sports performance lab. And I'm like, are you kidding me? So
Oh, yeah.
we're
Get
very
much better.
fortunate to have our shared practice at TCO, and he's an excellent mentor. I'm super grateful.
Yeah. Dr. LaPrade, I'm sure there's a lot of therapists that are on listening tonight that don't have the opportunity that Jill has, that maybe would like to. What can you tell us just briefly, what it is that you value so much about her, and why you feel it's so important that she's on your team?
Well, Jill's just fantastic overall to work with. And she's also a big patient advocate. So she works really hard to try to optimize their outcomes. And, we get together at least twice a week. And I think that's valuable. I do physical therapy rounds every morning after surgery. So Wednesdays and Fridays after my big days, we meet together with our therapists, our athletic trainers, my PA, and me, and we kind of all go through what needs to be done for that particular patient, because a lot of them in my practice are from out of town, and as she said, they're very unique injuries. We seem to see unique injuries weekly,
Yeah, yeah.
but they are unique injuries. So we need to make sure they can be their own advocates when they go back home, and that's what Jill is good at. Is even if somebody's only in town for a couple of days, she helps to get them on the right course. So even though there are a lot of revisions in complex cases, our patients do pretty well after surgery, so they're pretty happy clinics.
That's awesome. That's great. Well, I've put these in kind of an order. Hopefully this order is okay. I sent you kind of a tentative list of maybe some questions. And I thought we'd start out with I think is it pronounced Rothke? Rothke, is that right? Okay, the Rothke article, Revision ACL Reconstruction Causes and How to Minimize Primary ACL Failure. Great. By the way, great article. All three of these articles are fantastic. Fantastic. Depending on how long we talk on each one of them, we may not even get through all three of them, but we'll try to get through each of them. So one of my first questions, Dr. LaPrade, and again, Mike and Phil, Ashley, if you can get back on and you have any questions for these two, feel free to interject. I don't need to ask all of them, but the article describes a 5 to 25% primary ACL failure rate, which really seems certainly 25% seems totally unacceptable. I was just wondering what your thought is there any acceptable rate? I mean, is like 2% acceptable? What is acceptable when you're talking about, a patient that's a human that has a knee that they want to function? And I mean, is there any rate that's acceptable for failure?
I think there's probably an optimal rate of 2 to 5%. If your surgeon is in that range, that's pretty acceptable, because some people are going to have biology issues and not heal so well. They're going to have re-injuries and things like that. I think once you start getting above that, you need to figure out why it's happening and how you can make sure it doesn't happen the second time or the third time around.
Yeah, yeah. And so it's the obviously a very complex issue, and with lots of reasons why it can happen. What is and I don't think it's said in here, your personal favorite graft source. Do you have a favorite graft source for a primary or a revision ACL reconstruction? And what determines that, and why is it your favorite if you have one? Maybe you don't. Maybe you like to just
Oh,
focus on the person.
my favorite graft source is the BTB,
Okay.
because it heals better. It's a favorite source for professional athletes. But with Jill as my therapist, I can do a primary autograft BTB in somebody at 65, and they recover well and don't have a lot of pain. So I think using allografts and saying they're going to have less pain, it doesn't happen in my practice. I haven't used an allograft for an ACL since 2015. So we're looking at a couple thousand ACLs we haven't had to. So we usually have an autograft source. We'll start off with the BTB. Revision ACLs, when it's been used, we'll use a quad tendon with a bone plug, because they're stronger than just a regular quad. And then from there, you're looking at hamstrings, but you've got at least 4 chances, BTB on the other side, quad on the other side, to try to get it down correctly.
Yeah. Is it true? I heard I think it was at your guys' AOSSM meeting this summer. I think someone was saying that still worldwide, the greatest graft source that's used is the hamstring right now. Is that true? Is that
Yes,
accurate?
that is accurate.
Yeah.
Even though it's got a much higher failure rate and
Yeah, yeah.
tends to be a little bit looser, it's still the graft of choice, because it's an easy graft to harvest. It's inexpensive. So, you can use a cortical button on the femur and the staple on the tibia if you wanted to.
Yeah. What's the what do you believe the rationale for? Lately a lot of people are really on the bandwagon of using the quad tendon again. It went away for a while. I don't know if it completely went away, but people weren't using it a lot, and now it's like it's everywhere again. What's the big appeal to it now? Is it different than it was done in the past? Is it just kind of resurfacing again, and it's just kind of now in vogue again, or what's the deal with that?
Uh, I believe it's more marketing than it has actual data because it works. There's no doubt about that. But the cost for an ACL screw is maybe $100. The new quad tendon devices can be up to $2,000. So last year in the US, it was less than 5% of grafts, but it was more than 50% of the marketing that was done out there. So it's
Wow.
a lot
Wow.
of marketing. Our data shows that it works for our revisions, but the patients are a lot weaker. And we're
Yeah, yeah.
at 9 months, the quad deficit is still about 10% that below that of a BTB. So you have to be careful on who you choose it for.
Yeah, I agree with that. Your assessment of the strength there, because we have several doctors that use primarily quad tendons, and we've tested them on their isoconnect strength at 6 months and a year, probably about 100 people. And you're right, they're still even a year out, they're still a little bit weaker, I think, than you see with a BTB. So that's obviously a part of the rehab and what you have to deal with, but. The article that we were talking about describes one of the potential causes of primary graft failure as unrecognized concomitant meniscal or ligament damage. When you're in there doing surgery, don't you usually assess all of that? How could there be, meniscal damage or other ligament damage that's unrecognized? Does that happen a lot?
That's a very good question. Yes, it does happen a lot. And I I think if you look at the differences in meniscus repairs for some publications versus others, we had 87% of our ACLs had meniscus repairs with them in our first paper, and then the latest one was 85%. So if you look for them, they're there. I'm very aggressive at repairing it. So, some people may be more conservative, but we know that in particular for a medial meniscus ramp tear, that if you only look from the front, there's two publications that show that you can only diagnose it correctly 60% of the time. So you're missing 40% of them unless you go to the back of the knee and get a good evaluation of the attachment.
Yeah, that's a big percentage. Yeah, that's a big percentage then.
Hey,
Another thing. Oh, go ahead. Yeah, go ahead. No.
I think we're gonna have maybe like a quick TV timeout, like just like a 30-second TV timeout. If I think Dr. LaPrade's familiar with this guest, if he'll accept his invite to move to a panelist for about 30 seconds. He's texting me, but maybe not paying attention. Why do you keep declining to be a panelist, Dr. Plancher? Hold on. We'll give him one more chance. I'm just gonna say allowed to talk.
There he is. There he is. He's trying to get on.
Come on, Kevin.
All right, unmute yourself. Here we go. Dr.
Turn on your video.
Plancher.
Yeah, turn on your screen. Turn on your video.
He's I think in Chile right now, so I don't know what he's doing. Never know with this guy. You're on, Dr. Plancher.
Internet lag.
Okay, I just text him.
All right, here we are.
Oh, there he is.
There he is.
First of all, it's a big hello to Rob LaPrade. Rob and I, I don't want to say when, Rob. That would be embarrassing. But it's been a great honor to travel through life and sports medicine with Rob, and it's a great evening that you can get to see and learn from him. I did as well. But I want to say it's Ortho Summit and ISJPT. We can't make a better deal financially. I'm coming on because on Friday at midnight, the room rate jumps from $289 to $900. And so I encourage anyone who's considering coming, and I'll let all of you brilliant people and Ashley and Phil and everyone to say, I think we have great content great CEU, CME, and it's really run by you, not by us, in an independent program. And I encourage you to come so you can learn and take care of your patients even better than you take care of them today. Meet with physicians, meet with fellow PT, ATCs, and I thank you for the time, and I don't want to take it away from Rob. He has too much to offer this evening. So thank you, and I hope you have a great evening. I'm in Chile. It's a blizzard. I'm with the U.S. ski team, and so I'm going to try to stay warm.
All right. We'll see you next month.
Okay. Have a great evening. Thank you so much. Bye-bye.
See you, Kevin.
Bye.
Bye-bye.
Okay.
Okay. Thank you for humoring me.
Yeah, you're welcome. All
Yeah.
right. So let's jump back to the article then. Here, another one of the problems that are seen fairly often, and probably most of us have seen this once or twice. I don't think we probably don't see it as much as you, Dr. LaPrade, but when someone does surgery and puts the graft in the wrong place, so the graft is malpositioned, either too far anterior, too far posterior. Other than changing the joint contact forces and overall stress to the knee, how does that malplacement? Well, I've got two questions. How does the malplacement affect function? And secondarily, how do we as physical therapists, what are the keys to us recognizing that and noticing it that we need to draw, to someone's attention?
So that's a good question. Unfortunately, more than 50% of ACL graft failures in everybody's papers are due to malposition. So if it wasn't put in right, that's probably a major reason why they're failing, to go back to the 25% number that we were talking about earlier.
Yeah.
So, if it's too far anterior on the femur, what'll happen is that you can't flex the knee as much. So you have a deficit of flexion, or if you get all your flexion back, the graft stretches out. So that's what you have to worry about there. If it's too central on the femur, it's going to be basically positioned straight up and down, and it won't control rotation because the ACL is in an angle inside the knee. So if you don't have it angled correctly, it's not going to be able to control rotation. So you can have a positive pivot shift, and patients will have functional limitations, and your Lachman's test may feel entirely normal.
Yeah.
And then the other thing is, if you put it too far posterior on the tibia, you can also have difficulty with it being straight up and down, and basically it won't control rotation. And if it's put too anterior on the tibia, you could have impingement on the roof of the notch, because as you extend the knee, it'll pinch on the graft. And those patients may get a cyclops lesion and lack full extension. So all those things are the basic summary of what to worry about when you have these technical irregularities.
Yeah. Is it if it happens that often, obviously we're not orthopedic surgeons, so we don't know how to place a graft, but you have kind of a footprint there, right? Is it really, if you're a decent orthopedic surgeon, is it that hard to put it in the right place, or why is it happening so often?
I think if you looked at sports medicine trained physicians that have a high volume for ACLs, it's not really much of a problem. They may maybe off a few millimeters each time, which probably doesn't have any clinical influence. But remember, most ACLs in the US are done by people who do 10 or less a year. And a lot of them don't get postoperative x-rays routinely to check their position. So if you're not doing a lot, you may not recognize that you're having a problem, because the volume isn't there to recognize the large number of failures.
Yeah, great points. So Jill, since this entire article is talking about revision anterior cruciate ligament reconstruction, can you tell us how does your rehab change from a primary to a revision? What are can you give some of the people listening just some tips and things that they should look at and key into that you do different with a revision than what you would do with a primary?
Yeah, absolutely. I think it's, first of all, important to recognize that it is different, physically, psychologically, biologically, everything. And so, really connecting with the patient early on so that they understand, this is not just, getting another filling in your teeth at the dentist's office. So we really want to be done after this. So you talk about the length of the rehab process. You expect it to be longer. You expect each phase to take a little longer because you're wanting to give the biology a little more time to heal and recover. We talk about our patients like adding on 50% more time to the recovery because again, we don't want them saying, okay, well, I'm going to be back with my team at 6 months, right? And it's
Yeah.
like, A, that shouldn't have been the case the first time around, which is probably part of the problem. But then B, it's just like, actually, no, let's try to kick you a little further out to a year or later, along with as long as everything else also looks good. I mean, I just had a gal back testing who is 9 months post-op. She's going off to college for her freshman year. She wants to play IM sports. And I was like, you know what you're going to do your first semester is you're going to go to the gym. You're not going to play IM sports. You're going to go to the gym. We're going to test you when you're back home for winter break, and then we're going to talk about what is next for you. So time is something you've got to have that conversation with the patients so that they understand that the process is just going to be different from what it was the first time, even within their own self of one, but also certainly different compared to their friends or other, teammates or whatever who's going through a primary ACL. There's usually some sort of concomitant procedure that's been performed, meniscus. We have a lot of staging that is required with some patients whose tunnels widen. So, you're dealing with other procedures. You're dealing with a native graft harvest from that knee that it might be irritated. You're going through the same incision sometimes twice. Sometimes there's new incisions. So you're dealing with perhaps more surgical morbidity. For us, we really always want to, and so you've got to manage those things well. You've got to manage scarring. You've got to get the basics well done. We talk about 4 table legs, and you've got to have a sturdy table that you stand things on top of. And so it's pain and swelling control, motion, quad, and wellness. And in wellness, we talk about nutrition, psychological health. We talk about sleep. All of those things that you might not always mention. We mention every day in post-op clinic. So, and then having clear objective goals to drive your process because they need to understand their deficits. They need to understand when certain gates will open to them based on their recovery with objective data, not just time. So it's time, yes, super important on time, but also having clear objective goals that you're having them meet. And we might raise the bar a little bit on those goals in a revision context compared to what maybe you would allow for a primary ACL reconstruction.
It amazes me that I guess it's because it's not, it's not happening to us. We're not having the surgery. So, we don't see as taking extra time that big of a deal, but to the patient, a lot of times it's a huge deal. And you've really got to set that expectation and they don't always like it at
It's
all.
disheartening. I mean, if this is a teenager who's already missed one sports season because of it, and now they're looking at another one, it's a big deal. And you have to ask questions. Patients aren't going to volunteer that they're struggling with it. You need to ask that question. So at 2 weeks and at 4 weeks, I go through those 4 table legs and I check in on each of them. And like I'd say 75% of the time when I ask the question is when that patient will volunteer, actually, I'm not sleeping super well, or actually, I'm really kind of bummed out. And I was like, well, are you hanging out with your team at practice? Well, no. Well, why don't you just go and like do manager duty or something so you can be around your social group? But it takes me asking and opening that door in order for them to volunteer that information up to me.
Yeah. Yeah. It's got to be frustrating. I mean, it's got to be horribly frustrating. Any revision, whether it's the knee or the shoulder or whatever. You touched on, I don't even have this on our list of questions, but you touched on nutrition. We had, I believe, Phil, wasn't it? Dr. Buddy Savoy was talking about nutrition and rotator cuff repairs and
Yeah,
revision rotator cuff repairs and how important he thought it was.
yeah, we actually had a PT do grand rounds on nutritional concepts around recovery last week. So
For orthopedic problems.
yep,
Yeah.
he's big on that, definitely.
So Jill and Dr. LaPrade, do you talk to your patients about nutrition? I mean, just eating right and appropriate amounts of things?
Because we see, I mean, I'll chime in first, then Doc, you can jump in. We're fortunate at our center that we do have sports dietitians who are on staff. And so I can talk about it with them and introduce the concept, and then I can make a referral to somebody who's actually medically trained to manage it better than me. But I think it's just important because you get a patient who's saying, well, gosh, I'm not being active at all, so I really need to cut back on my calories, but they're healing. So they need and then we're going to ask them to load so we can strength train them. And then they're on this very restrictive intake on calories, or they're not eating a certain food group because they don't want to gain weight, perhaps when they're non-weight bearing, or whatever it might be. So it is one of the 4 things that we talk about with every single patient who's had surgery, not just revisions, because it's just silly if you think about it any other way. Like how can the fuel intake into our body not influence healing and recovery, and mental acuity, and just everything. So it is something that we introduce, and then we pass the torch to a colleague in patients who probably do need help. And also if they're revisions, we see that primary ACL reconstruction show bone mineral density loss. So now you put that person that's been offloading for 2 years, you put them back on crutches because now they've had a meniscus repair. So they're certainly going to have a bone mineral density situation that we need to address both nutritionally and education, and also with a loading progression that will help overcome it. Mm-hmm.
Yeah, no doubt, no doubt. One more question for you, Jill, and then we'll get maybe back to a couple more with Dr. LaPrade. How do you, so with these, my guess is, I mean, I've seen revision ACL reconstructions before. Usually it seems the quad atrophies more, and usually it shut down maybe even a little bit longer after a second surgery like this. What kind of things do you do early in rehab in revisions to try to speed that up, getting their recovery back, maybe not losing as much function as they do? What kind of pearls or tips do you have?
Yeah, so with that, we're hitting stim early on. We're getting
Do you
it
do it
on
on everybody? Do you do it on everybody, or
pretty
only just
much.
those that really
No,
can't fire it
pretty
well? I mean, if
much.
they're, yeah.
We're wanting to embellish the contraction intensity with everybody. I've been dabbling more with the Delaware protocol. Ariel Giordano and I were at the AASPT meeting in June, and I've known about it for years, but you just kind of think, well, but seeing her do it in person, I was like, you know what, I'm gonna see how people do with this, and it's been a nice tool. They've done such a good job of making resources and how to follow that protocol, because what you do see is like a doubling down of the inhibition on the quad in the revision situation, because it's not just, an effusion based inhibition. You have this central activation deficit. There's probably something on a cellular level that's happened. All of our colleagues who dig into AMI, it's multifactorial.
Mm-hmm.
And so the least I can do is try to address as many of those factors as possible. So we're stimming right away. We're doing BFR as soon as we get some, a little bit of early incisional healing. But within week 2, we're starting BFR at a reduced cuff occlusion percentage, I should say. So we're not jumping right up to 80 right away, but we're getting the cuff on them right away with BFR. And then we're using some type of serial objective testing. With a Tindeck costing $200, there's really no reason why people are not doing serial quad testing weekly even. You can be getting input back to the patient that they can see of, here's my quad force output today, and then here's what it is in 2 weeks. You put them in a safe position for whatever was done surgically at their knee, but full extension quad isometrics and straight leg raises are not going to restore quad strength. You do need to get them into a flex knee position, but we might hold our revisions at a 60-degree ISO or at a resisted arc deeper in the range of motion longer than what we would be worried about perhaps with a primary ACL. But we've got to get them in a flex knee with stim on, utilize BFR, use the tools at your hands, and measure.
Yeah. So can you just briefly, can you tell, because probably a lot of people don't know what you're talking about in regard to the Delaware electrical stim protocol. What does that entail? How's it different than, everybody that throws on Russian stim
Yeah.
after
First
surgery?
of all, they've created a lot of great resources. So go to the University of Delaware physical therapy page. I'm not getting paid to plug it. But they put energy into making nice resources, and I know how much time that takes. So, and they've got a YouTube video that walks you through the entire protocol, but instead of using just a volitional quad contraction, you're actually just using a stimulated quad contraction where the patient's not kicking out, but the stim is turned up enough to create output into like the Tindex strap or the Biodex or whatever you're using to measure force. And I'd be interested to chat more with my colleagues at Delaware about it, because there's a lot of different observations you make. You acclimate patients to a higher intensity. They're getting a weekly measurement that they're seeing of their output, so it creates motivation. I think a lot of times we get so deacclimated to load that we let our patients fall further than what they should. And then we have to recover from a lower starting point. And so essentially patients are at 60 degrees of flexion. They push out maximally what they can. And then you go down to 50%. You use the stim to bring them up to a minimum of 50% of what they can do volitionally on their own. With just the stim, you're doing that. And then you run them through a workout where they're doing 15 reps of a 12-second on, 50-second off. Quad workout, and then they're pretty roasted by the end of it. And that's their quad workout for that day. They get muscle soreness. If they're not getting joint soreness, that's the ideal, right? Muscle soreness, not joint soreness.
Yeah, good. Thanks for offering that to everybody, because I think a lot of people don't fully really understand that. So we have you guys probably know we have this question and answer area, and John Schneider, I think he was talking about when you were talking about with the revision patients, just letting them take more time. He just responded, more time is more better, which I think we agree on. And
well
then
said.
and then an anonymous attendee wanted to know if you could just quickly restate your 4 pillars. So that's a great concept, and they just want to.
Yeah, those 4 table legs. It's pain and swelling control, mobility, range of motion. So we include like patellar mobilization, soft tissue in that category, quad activation, and then wellness. Wellness includes sleep, nutrition, mental health, all of those things.
Perfect. Thanks for saying that again. So, Dr. LaPrade, back to you. Bone tunnel enlargement is a issue a lot of times with revision repairs. What can you explain to everybody what causes that, and how often do you see it, and what is it that you guys do to navigate around it?
So bone tunnel enlargement means that if you reamed a certain size tunnel, so like for a hamstring, probably the average is 8 millimeters. At 1 year, that tunnel may be 12 millimeters in diameter for 90% of hamstrings, which isn't a problem unless you tear your hamstring graft. And then if it's even bigger than that, it's really difficult to put a new graft in there and have the biology work, because the tunnel's too big for the graft. You're not going to have the graft hitting the edge of the tunnel to have better incorporation. So every time we see a failed ACL reconstruction, we're getting a CT scan, a little bit more accurate than getting an MRI. We get to see the tunnel diameter. And if the tunnel diameter is more than 14, it's like universally accepted that you have to do a bone graft before you can do the next surgery. In our practice, it's a little bit more involved than that, because we look at whether the tunnel is in the correct spot or if it's a little bit offset, because if you put the tunnel in the correct spot for the second surgery and you merge into a poorly placed tunnel the first time, then you're going to have the same type of thing where you'll have converging tunnels. So
yeah,
we look at all those factors, but it's best to evaluate it for every failed ACL reconstruction. And unfortunately, almost all first-time ACLs are going to have the tunnels get a little bit bigger for hamstrings, bigger for allografts, a lot bigger for allografts. So if they fail, that almost guarantees you're going to need 2 surgeries.
Is that bigger for those two because the tissue that you're using for that is larger, or is it just something happens biologically?
Well, I mean, there's probably a biologic reaction with an allograft, because there's some, graft-host interaction that's going to cause a little bit of increased bony absorption around it.
Uh-huh.
And when it fails, it's a problem. A lot of them don't fail, even though the tunnels can be huge and it's not an issue. Hamstrings, for some reason, if you look at the Norwegian studies that have been out there, they looked at CT scans on day 1. Then they also looked at it at 1 year, and it was 50% enlargement for hamstrings, the tunnels alone, even though all the grafts worked. So it's probably a natural reaction with hamstrings. With BTBs, most of it's bone, so we usually don't see the problem with the tunnels getting bigger unless it's with an allograft.
Gotcha. That makes sense. That makes perfect sense. Can you tell us about the resurgence of the LETs and why they're becoming popular again now?
Yeah, the LETs are becoming popular because we found out, especially with hamstrings in younger patients, that the failure rate's unacceptably high when the tibial slope is 12 degrees or more. So our Australian colleagues have published that the failure rate's almost 80% by 20 years. And our Canadian colleagues have shown it's about 40% within 2 years when they looked at the stability study that Alan Getgood ran. So we're trying to look at better ways for the most common graft. And one of the ways to further augment it and try to get it to heal is to add an anterolateral complex surgery, whether that's the anterolateral ligament or a lateral extraarticular tenodesis. And the most common one is the modified Lemaire procedure. We take a strip of the iliotibial band, we route it under the fibrocollateral ligament, then reattach it just slightly posterior to that. And it does unload the ACL. The problem is that it might cause some overconstraint that we still haven't investigated a lot clinically. Alan has published an MRI study that showed that the cartilage is a little bit overloaded. We don't know if that's clinically important or not. So it probably shouldn't be used in everybody, but adolescents have the highest failure rates of all. So that may be a time to do it. Contact athletes, slope 12 degrees or more, heel heights 5 centimeters or more. There's a much higher rate of failure with those types of laxity patients. So looking at those, as well as if you have to use an allograft, all those may help to add either an anterolateral ligament or LAT graft to unload it and give a better chance that the failure rate will go down.
Yeah, we typically don't see it unless it's like in a revision case. And there's not a lot of people here that I know of in Kansas, where I'm at, Wichita, doing a lot of them on primaries, but they do a fair amount on some revisions. So maybe we'll see it continue to grow. So Jill, just speaking about the LETs, does your PT change much based on someone having the ACL, either primary or revision with the LET? What kind of things do you change with that?
Yeah, I mean, it does. Does it change the overall trajectory of their entire course of recovery? No. We debate this amongst our group as far as, why do we see these lower failure rates when the LET is on? And we've kind of agreed that the soreness that they have early on might slow them down from doing dumb things. So that's the theory. But that lateral incision, is uncomfortable. So it's one more incision that you need to manage. It's swelling that you need to manage. The lateral side of the knee being very fibrous doesn't really absorb that swelling super well. So we'll use different foam inserts around that incision to help express the fluid out of that area. Patients will be sore up at their TFL. I mean, you think about the pathway of the iliotibial band, it's not just this separate segment distally, it's a continuous up proximally. So we stay away from kind of hip flexor based quad strengthening with those patients. We stay away from a lot of varus or abduction stress early on, because we don't want to fire into that TFL, which is already tender, creating tension down along that pathway. Because he's essentially pulling a strip off and anchoring proximally and distally. So we want to let that heal in a little bit before we put a lot of tension down that lateral column of the leg. And I mean, it's really, patients may notice, Doc was talking about it can create a little bit of overconstraint. Some of the studies looking at overconstraint show it's more pronounced in the first 6 months. It lessens in the second 6 months of recovery. So patients may experience some mechanical type symptoms anterolaterally with like arc of motion quad training. So if that happens, you maybe stick with a single angle isometric or multi-angle isometrics, or you bring them through an arc of motion where you're not eliciting that mechanical symptom. So you make that adjustment and calm the patient down by just letting them know that this is a graph that's probably going to adapt a little bit with time, and that you expect to see it improve over time, but it's not unusual for it to happen, especially in the first, 4 to 6 months post-operatively, potentially.
Yeah, I think that's a great tip for everybody listening. What she said there, what Jill said about letting them know like something happening that they see as problematic, but it really isn't problematic. Letting them know that it's maybe a very normal part of the process, and in time it's going to go away. So they're not, just constantly worrying about it and that, bringing them down. You let them.
Well, and with that said, you don't want them creating a flare up and irritability in the region by repeatedly, because then we get into an inhibition and their quad control goes down. So you want to adjust around it, but it's okay to reassure them that it's not unexpected completely.
Yeah, you said so interesting point you made. You like you said a little foam pad over the incision. So do you mean almost kind of like we do a horseshoe pad around the ankle when someone's swelled, just to keep the swelling down and keep? Yeah, it's great.
Yeah, we make these little burritos too. We use different size foam because one of our lymphedema therapists told us that the different densities of foam allows for the lymph fluid to kind of snake through. So we're big on learning from our peers who are slightly more expert in different domains and applying that to our surgical population.
Yeah, I love stuff like that. There's just like a little tip of that. So that little tip that you gave right there to me was worth this entire, really like worth the entire hour because I haven't done that. I haven't even thought of that, but now you bring it up. It's just like it makes common sense. I mean, why haven't I been? Why don't we do it? So God, thanks for that. That's unbelievable. Phil, do you got anything you want to add? You're just sitting there eating chips or
No,
something. What are you eating over there? You're just
no,
eating
I'm just chewing on the ice. This is just
chewing on ice.
it's a
Okay.
fascinating conversation. You're doing a great job, Rob,
Okay. I
and
I
Jill
don't want you to
and
feel like
Dr. LaPrade.
I'm hogging the whole thing. If you have
No, I'm
things to
loving
add,
it.
feel free. Okay. So you guys, you okay if we go to the next paper? All right. So the next one is Vanderwall. I know that I can say that one, Vanderwall. I'm pretty sure I'm saying that one with confidence. This has got a really long title. I'm just going to leave it at meniscus tears and miscellaneous. How about if I just call it that, Dr. LaPrade? This
That's
is like a
perfectly fine.
very long title. So you're like an expert at meniscal repair, meniscal surgeries. The meniscal function is so I think undervalued by a lot of people. I mean, it's so important, not only for shock absorption but decreasing tibial translation. Um, a lot of people don't understand, I don't think, the ramp lesion and how it affects joint biomechanics. Can you explain to everybody what that is? And I think you mentioned earlier how you see it, but what is it specifically? How does it occur? Are there certain injuries that it occurs with? Um, do a lot of people still miss it? Just tell us, I guess, what you know, maybe in a nutshell, because I'm sure you could talk about it for hours.
It's a lot of questions.
I know, yeah.
So the reason it's called a ramp lesion is because the posterior capsule attachment to the meniscus comes down and looks like a ramp. So in orthopedic surgery, they kind of call it the way it is sometimes. So
Yeah, yeah.
it doesn't have a straight attachment. It comes down, there's a little bit of a dip and attaches to the meniscus. So that's why it's called a ramp lesion. So it's the capsule attachment to the posterior horn of the medial meniscus. And it's the part in the tibia is the meniscal tibial, and the part that comes from the femur is the meniscal capsular. So it can be within about 3 millimeters of the rim of the meniscus to functionally act as a ramp tear. Now, when you do have a ramp tear, it'll cause increased anterior tibial translation when the ACL is out. And it's also going to put extra stress on an ACL graft. So when I examine a patient and they have a 3+ Lockman, I know that there has to be some other meniscus tear there, and it's almost always there. So I can usually tell on clinical exam that there's a ramp tear, even if they don't have a lot of meniscal pathology signs like pain along the medial joint line. A lot of these patients, you can't flex them back too far, but you can do the Lockman's test. And if you see that, it's not an ACL tear, is what I tell patients. It's an ACL plus. So 3+ Lockman, that's not an ACL. It has to be something else. It can be a lateral meniscus root, can be your ramp, but those are the most common. In terms of how often it's there, when we first started diagnosing these probably 8 years ago, when the first publications were coming out, the literature was saying that they're present in 12 to 15% of all ACLs. The latest papers now are 45 to 50%. So we're getting better at diagnosing them. They're not increasing in frequency. It's just that we're getting better at diagnosing them, making a trans-notch view to look back on the meniscus and see it. We'll take a spinal needle and gently trephinate the MCL when we're highly suspicious. And sometimes you can't see it at all looking from the back or the front, and you do the spinal needle and there's a huge ramp tear there. Because the ACL, when it's torn, will make the whole tibia sublux and it can hide it. So it's called a hidden lesion, is what some people have probably heard of that. And that's what it means. You just can't see it. You have to really search for it to be able to see it.
So Phil, if what you're saying is true, which I believe you, if Phil and I are each seeing, 10 ACL patients, in a 2-month period, and none of them are having ramp repairs, then I almost half of them are being missed. Is that right? I mean, is that
That's
accurate?
probably 30 to 40% are being missed.
Yeah, that's a lot. So what happens to that patient when you miss it and you're doing their rehab? What kind of things will you see? How will we
So
know, or will it just kind of go slower? They'll have a little more laxity.
what you hope is that because of the ACL tunnel drilling and the hematoma in the knee, maybe it'll have a chance to heal. But if it doesn't, that's going to be your ACL. It's going to be a little bit looser. not as tight as you want it to be. And that's the concern that we have, is that we know when we repair them that the ACLs are very stable on stress radiographs. So we have some objective information in addition to the clinical exam.
So how do you describe meniscal ramp lesions and ramp tears with us? How's that different from the root tear that people hear about nowadays?
Yeah, so the meniscal ramp tears are basically what we consider a peripheral tear. They are stable tears once you repair them with an ACL. So it shouldn't change the rehabilitation protocol unless there's a radial tear within it. The root tears are totally different because they are either a root tear is a radial tear within a centimeter of the main meniscus attachment, or it's the actual detachment of the meniscus. And those are not stable. So when you put weight on those, they tend to cause distraction at the repair site. And that's a big problem, because when we do it biomechanically and you have a root tear, it's equivalent to taking the whole meniscus out, because what happens, the meniscus squirts out of the joint. There's no hoop stresses at all. The joint's overloaded. So it can be a source of rapid arthritis if it's not recognized and treated. And so you have to treat them a little bit differently postoperatively, because you can't walk on them the first 6 weeks. Our friends in Asia have done a lot of second look scopes, and 6 weeks seems to be the critical time. And I know that our friends in Asia also have patients that are half the size of Americans. So
Yeah.
so we know we're not going to be better than that. So 6 weeks is pretty key for your root repairs to be non-weight bearing.
Yeah, that's plenty. That's plenty. The did you have something, Phil? You look like you were getting ready to say something. No?
Well, I was just really enjoying that conversation. I just think that that's amazing stuff that we don't always think about in rehab. So I really appreciate the conversation.
Doc, if you when you look at like historical studies on meniscal repairs and outcomes or meniscectomies, it seems like the lateral meniscal tears and meniscectomies tend to, over time, typically do way worse than the medial meniscus tears. Was that potentially because of like root tears that were maybe missed, or is it just the fact of the geometry of the joint, or maybe a combination of both?
I think the low contributing factor is the bone bruise that happens in the lateral compartment. That may cause a little bit of arthritis. But now that I see these patients back, and I see the ACLs that had a root tear 10 years ago, lateral compartment, and they weren't repaired, they come to see me because they're having lateral compartment pain, joint space narrowing, osteophyte formation. So they do get arthritic. It's important to recognize the lateral meniscus is a huge shock absorber compared to the medial meniscus. It absorbs, on average, 70% of the forces, but there may be some people that absorbs 90% of the forces. So you detach the meniscus and it's not functional, they're going to be at a high risk of overload. And in addition to putting extra stress on an ACL, you have a much higher risk of getting arthritis when they're not repaired.
Yeah. Um, I think that's all the questions I had for the second talk. I didn't have as many, or not the second talk, but the second paper. So we can move to this last one, which is, I believe it's.
Hey, Rob.
Yeah.
Question. Someone wanted to know if the 3+ Lockman was under anesthesia or was that on clinical exam?
That can be either. So when it's on a clinical exam, then you have to be really worried if you're worried about guarding, because that may mean it's both a ramp and a lateral meniscus root tear. So you have to look at that. But on the exam under anesthesia, if I don't see that they have a 3+ Lockman and a 3+ pivot shift, I question whether they actually have a root tear that we're worried about, or a ramp tear. And almost all the time, the clinical exam correlates with what is going on when we see them on the exam under anesthesia. So I think that's a good question, and that's accurate. It can be clinical too.
Yeah. Nice. The last study is Tollefson.
Tollefson. Yep. Luke.
Okay. Um, supratubercle anterior closing wedge osteotomy. No changes in patellar height and significant decrease in anterior tibial translation at 6 months postoperatively. Now, I got to be honest with you. I didn't come up with these questions, Dr. LaPrade, so I'm going to try to ask them appropriately. These came from Barb Hugenboom, who's usually with us. but wasn't able to make it because she found out last minute she had to take as a granddaughter to soccer, right, Phil? Is that what it was? Granddaughter to soccer. So sorry, Dr. LaPrade, but soccer with the granddaughter beat out talking to you.
Yeah, definitely takes care of us.
Um, in your experience, Dr. LaPrade, do most surgeons actually consider tibial slope in their algorithm for surgical planning? I can tell you, like here, I don't. Again, I hate to say all this because it sounds like we don't like know what we're doing here, but I don't know that they look at tibial slope. To be honest with you, do you feel? Do your guys, are they all looking at tibial slope? Do you know?
No, I think some of them do, but I agree with you. That's something that needs to be looked at.
Fairly real. So Dr. LaPrade, what is do most surgeons look at that, or are you fairly unique in that? Are there a lot of ACL surgeons, knee surgeons that look at tibial slope in relation to ACL injuries?
It's probably the hottest topic at AOSSM and ANA right now in terms of the attendees in the audience that hear about it. So if you go to the meetings, you've heard about it.
Mm-hmm.
Problem is that it's only been out there for the 3 years before the pandemic and going forward. In the pandemic years, most of us missed 2 or 3 years and they're catching up. But almost everybody who is an academic orthopedic surgeon that does a lot of ACLs is looking at slope because the papers are being generated pretty quickly out there.
And they're pretty legit, right? That it does.
In terms of the biomechanics, so we did one of the first ones on it. As the slope increases, the force goes up on the ACL, and at 12 degrees, it really goes up a lot. And almost all the clinical studies show that 12 degrees is the key part. Once you get a slope above 12, you're going to have increased force. And I think it's important to look at our colleagues. So veterinarians used to do ACL reconstructions on dogs in the 1990s, and they all failed. And they figured out about the year 2000, if they just did a tibial slope leveling osteotomy, that's all they need to do for a dog, and it made their knee stable. So there's no more ACLs done in dogs. When they say the ACL is done, they're actually doing a tibial slope leveling because dogs have such a big posterior slope.
Yeah,
So
I've had friends that have had that done on their dogs. Yeah.
So it took us about 15 years to kind of cross train ourselves and realize the veterinarians had something, and there's some people that have dog knees.
The canines, yeah, the canines got it right. Yeah.
And that increases the stress on the ACL, so it's a high risk of failure. And that's kind of ties in with the anterolateral ligament and LET because we know that 12 degrees is a key point, and that's where we're all starting to look at adding in the LETs and ALLs for slopes 12 or more because the failure rate's higher.
Yeah, Lucy Salmon, I just pulled it up while you guys were chatting. It's the 2018 AJSM article. It's a 20-year outcome article where she really identifies that failure rates are significantly higher among individuals with an elevated posterior tibial slope. So I would say that's an article that most talks are referencing. It's a good read to put in your library. I can send it to Ashley if you guys want to add it.
Oh yeah, that'd be awesome.
Mm-hmm.
Thank you. So, Dr. LaPrade, how many? Barb wants to know how many of those procedures do you do annually? So the osteotomies, how many of them are you doing now annually? And is it reserved for those that fail, or are you doing it on primary reconstructions now as well?
That's a good question. We're doing about one a month, so we're averaging 12 to 15 a year. They're only for revisions. There are some people that are starting to do them for primaries. I think it's hard to talk a patient into it for revision. But it may be appropriate that we find out there's some patients, and hopefully the people that are doing it are collecting their data so we could see if it makes a difference.
Yeah, yeah. It's any osteotomy like that it's like those are very, at least what I've seen, are very painful procedures for the patient. So that I can see why they're not wanting to run in to do that just to try it out and see.
Yeah, I'm lucky that I have Jill there because we could do that as an outpatient and get them in physical therapy the next day, and put a good ice cold machine on them so it keeps the swelling down. So we can do that. I think the biggest technical issues is you just want to make sure your therapist knows you don't want to increase the recurvatum. So when we close the tibia down, we have to bring them up about 20, 30 degrees to make the edges come together before we put the staples in. So they can have a lot increased heel height, which is also bad for an ACL. So as part of the therapy, we tried not to hyperextend them at all for the first few months. And most of them tend to scar in. So we only end up with 1 centimeter or 2 of increased heel height. But if you started stretching them right away, you can end up with 10 or 15 degrees
Yeah,
of
you're in problems. Yeah.
increased hyperextension.
Rob, there's a Q&A here.
Yeah, I was getting ready to go to that. You can ask him if you want.
Okay, so Doc, is the ACL-R surgery combined with slope correction always a two-stage procedure? Asked Mohammed.
So right now it is in most centers because we're doing it for failed ACLs. So we'll decrease the slope, get it down to about 4 degrees, which is what we're trying to shoot for. We usually use the wedge of bone that we take out and use that to bone graft the tunnel. So that way it's almost a virgin knee when we come back and have the osteotomy heal about 6 months, and we can ream through a new tunnel.
Awesome. And I'll jump to the next one. It's probably little Jill, little Dr. LaPrade. Any suggestions for PTs, ATCs who need to advocate for patients when an osteotomy may be helpful in terms of preoperative planning, particularly when surgeons aren't thinking of this? How can patients or PTs be advocates of this if that indeed may be something that benefits the patient?
I mean, the challenge there is the PTs aren't necessarily going to have, they might see the images, but to know how to calculate a lateral posterior tibial slope is kind of tall clover. So I would say that if you have a patient who's in a revision situation, the best thing to do is to say, let's find you a surgeon that sees a lot of revision cases. Let's find you somebody who's, fellowship trained can be nice, is involved in national and international societies, has maybe published a few things on the topic. I don't think that's maybe the time to have someone whose practice is broad. I think you should probably be dialing in on someone whose practice is more narrow, and to be okay with asking the clinician that they're going to see, how many of these do you do in a year? I like to coach my patients to ask the right questions so that they can earnestly come to that decision kind of organically rather than me trying to back channel it to somebody else. I think you see more surgeons not always getting comfortable with their own limitations, especially when they have neighbors, even sometimes in their own community, who see things at a higher frequency. And so you do hope that ultimately people are putting the patient's best needs first. But I just like to arm them with the appropriate questions to ask and the appropriate information to seek out.
I think it's a really tough area for a therapist because you don't see the CT scan, you don't see the MRI, you don't see the lateral X-ray. And like Jill said, it's hard to measure. But I think if you see somebody that has 2 or more failed ACLs, I think it's time to see a specialist to see why they failed. Because you need a comprehensive workup to make sure it doesn't fail again.
And I've even, we had a young lady in from out of town today who, in addition to her undergoing a staged revision procedure, she'd had 6 prior surgeries, like a couple patellofemoral instability surgeries, and I was just like, your connective tissue seems problematic. Let's talk to your primary care provider or your pediatrician about getting in to see the genetics clinic to rule out Ehlers-Danlos, some other connective tissue pathology. And you really need to see a genetics counselor, a geneticist for that. And, again, you're talking about bone density compromise again and again. So we do have to zoom out. And if you have a 20-year-old who's had that many procedures and no one's ever discussed systemic health with them, that's a problem, because now I'm great, your ACL keeps giving way, but what about that vessel issue you're going to have in about 6 years that someone could have helped you avoid? I mean, you just have to think holistically.
Phil, you can attack any of those others, or we you're good. You're good. Or you're muted now again.
He mouthed all good.
Yeah. All good. Yeah. All right, guys. I think we're at our believe it or not, we're at our hour time limit. This is went really fast. It was really great, really unbelievable topics. Thank you, Dr. LaPrade. Thank you, Jill, for your insight, your wisdom, and helping educate us today about all of these complex knee problems. We know you're both really busy. We really appreciate you and value your time, and we're so happy you could join us tonight. And hopefully in the future we can have you both on again. We'd love to have you again, I think, anytime
People
soon.
in the chat and question and answer already saying, can you have him back?
Yeah.
So we'll have to do that. Thank you guys so much. Don't forget, guys, I will post the recording as soon as I find, an hour to do it.
Thanks for having us, guys, and all the behind the scenes effort.
Yeah, I'll add the paper that you mentioned to the file where we put your papers we discussed today. So thank you so much, guys.
Yeah, thank you. It was a pleasure.
Thank you.
Thank you. Have a good night.
All right, bye now.